be grateful if I could ask some questions, Leila. I'm not sure what procedure there was for being able to ask questions.
Yeah, so we sent them around before, and what we've done is allocated them to people. I'm aware that you want to ask some questions as we go, Debbie. If you could indicate when that is, and I'll do my best to make sure that those are fitted in. But if you could put it in the WhatsApp group at what point you'd like to come in,
we'll do.
That would be ideal.
Lovely.
Okay, I'm going to get started. So welcome everyone to the first oral session of the inquiry that this all-party group on coronavirus is doing, in particular, looking at the issues to address before a potential second wave. I think our evidence session is coming at a very timely moment where we're seeing repatriation from Spain because of concerns that there is going to be a second wave in Europe. And if we are learning anything from the first experience of coronavirus, it's that if we look to Europe and something is happening there, sure as fire, it's likely to be happening here. And so I think the urgency of making these recommendations to government is all the more pressing. We've got three very interesting people giving evidence today. And I'm delighted to be able to welcome Dr. John Puntis. Have I pronounced that correctly?
That's right, Leila, yes.
Thank you so much, from Unite the Union, and the doctors in Unite part of that. So thank you so much, John. Dr. John Puntis is a recently retired consultant pediatrician at Leeds Teaching Hospitals with 42 years experience of working in the NHS. He's also an editorial board member for Archives of Disease in Childhood, has published a number of letters and papers on COVID-related matters over the last few months, and also contributed to the Doctors in Unite position statements. We'll be taking evidence later on from the NHS Confederation and the BMA. But John, you are very, very welcome. Thank you so much for joining us. If I might perhaps start by asking, based on your experience talking to others in Unite and also your own experience, have you been working on the front line in the last few months, or have you been?
No, I haven't. Like a lot of retired doctors, I was invited to return via the GMC, and I said that I would do. That process of recruitment was outsourced to Capita, and it was pretty slow. So there was no contact for 3 weeks. Then I had to provide various documentation. Then there was silence for about 4 more weeks. And then I was told that I wasn't actually needed, and was invited to participate in the test, track and trace system. Mm-hmm. So that's a story in itself, but the process of re-recruiting recently retired staff did not go well, I think.
Mm-hmm. And what are the main issues that you, as part of Unite, have heard from others, have been encountering? What are the sort of the top areas? We know that PPE, of course, was one. You just spoke about the lack of recruitment or coherence in the recruitment process for getting people back in, with the view to what we need to do to change something to make sure that we avoid a second wave. What, in your opinion, John, is the top 3 things that we need to be focusing on in this inquiry?
Well, I think number 1 would be actually having a fine test, track, isolate and support system that works. So the question is, how do you have one that actually works? Because what we've got at the moment isn't working in terms of identifying the necessary number of people who are infected and their contacts, and then ensuring their contacts isolate. So it cannot deliver, and I don't think it will deliver unless it's redesigned and it's based much more locally. So that's one thing. I think PPE is a continuing problem. It caused huge anxiety, as everyone will be aware, but I have 3 young relatives who are frontline doctors, 1 on ICU, and they just didn't have the right kit. And that was never really fully resolved. And interestingly, one of them who felt vulnerable on a palliative ward for the elderly, cohorted because of having COVID, they've now found with the antibody testing that many of the doctors, nearly all of the doctors with the lower grade PPE are antibody positive, indicating that they've had the infection, whereas those in the very high risk areas, intensive care and A&E, who had the higher grade PPE, are almost all antibody negative. I think that's a very interesting finding. I think the correct interpretation of that is that you need to have high grade PPE for everyone who's at risk. I have to say the local management interpretation of that is that the doctors on the ward have been careless with things like social distancing and hand washing and using of PPE, which I think is a very negative and unfair interpretation. But I think is illustrative of the fact that it's been quite difficult for doctors and other healthcare workers to speak out about lack of PPE because often a fairly heavy-handed management has come down and complained about them making a fuss. And that's particularly difficult, I think, for more junior doctors.
When you say heavy-handed management,
trace.
Sorry, carry on, John, I interrupted you.
PPE. And then I think the public health message has been very garbled. And I think there's a lot to be said for having a much clearer public health message. And this is not about one thing being the solution, for example, 2 meters rather than 1 meters. It's about having a raft of different things which will have an impact. So it's social distancing, it's not going to big events, it's not going to crowded areas, it's continuing with respiratory hygiene and hand washing, and it's mask wearing. And it's all these things together which should become the norm for everyone. And within that, which is kind of a fourth thing, it's actually saying we need to be able to identify cases very quickly. And that's probably people having a lower threshold for reporting symptoms which are not classical. So it's not like when you're really ill, you've got high fevers and persistent cough, but it's when you've got things like rashes, diarrhea, tiredness, myalgia, muscle aches, these kinds of things, which would merit testing to see whether you've got it. And this is something which is being flagged up by the clinical online University College, King's College app, with about 4 million people reporting symptoms. So I think that's another thing as well.
Thank you so much, John. That's 4 very important things. I'm going to pass over to Clive Lewis, MP now.
Yeah, thanks, John. Thank you, Leila. John, can you just kind of give us a kind of an understanding of from your perspective, of the support that government provided to you in the areas where there were problems? I'm just trying to get a feel for you seemed to implied earlier on that it did seem quite chaotic. Can you just talk us through what those problems were and how the government attempted to overcome them and how effective they were?
Well, I think if you look at PPE, first of all, there was the Operation Cygnus exercise and report, the pandemic planning in, I think, 2016, which sort of pointed out the need to have lots of PPE stockpiled. And yet that wasn't actioned, and stocks were both run down and allowed to go past their use-by date. But instead of kind of honestness and openness about that, we were initially told that there was plenty of PPE, and that came from the Deputy Chief Medical Officer. Then when hospitals were clearly experiencing problems getting PPE, the government said that the problem was one of distribution, when it became clear that that was only part of the problem, and certainly there were difficulties with distribution, it was then said, actually, it's probably health workers overusing PPE and using it inappropriately, which I think was a very, I mean, I would see that as, in a sense, a sort of typical management response, to turn the problem back onto the workers. But I think that was extremely unfair. And then we were told, actually, the problem is we don't have enough PPE because it's a world pandemic and demand has gone up, and we're trying to get kit that everyone else wants. So there was a whole changing narrative, which was very unhelpful. And in terms of accessing PPE, NHS logistics is one of these, I think, failed privatization endeavors that was done to save money, but has led to an extremely complicated web of contracts for who actually supplies and distributes PPE. And one of the main players is Unipart, and they simply didn't have enough stock. And they started making decisions about how much of orders they would fulfill. So trusts were requesting a certain amount of PPE and then not being sent it. It clearly varied, because my understanding is in Leeds that my own trust, or where I used to work, had adequate PPE throughout, but it's also clear that in many places they didn't. And a British Medical Association survey showed at one point in April that 48% of doctors were actually buying items of PPE for their own personal use. This is a situation which I'm not confident has been fully rectified in terms of ongoing supplies. And of course, the demand has dropped, but there's every likelihood that it's going to go up again. So sorting out supply side of production and supply side of PPE, I think, still critical.
So you don't think that there have been any kind of fundamental changes to the supply and distribution of PPE since the last set of shortages that took place at the height of the pandemic?
There may have been some. I don't know about them. And I think part of the problem, as I said, comes back to the extremely complex set of contracts that are now in place. So there's many different players involved. There's something like 13 or 14 different contracts, with Unipart being a big one. But supply of PPE actually falls across 3 different domains. So it's all become much less joined up, I think. Yeah. Sort of common theme that fragmentation actually sometimes appears to be offering a cheaper way of doing things, but by introducing different players. But actually it means that delivery is much more joined up working, and delivery is more complicated.
I'm aware of time, but it's my final question, really. Apart from PPE, were there any other areas where you felt that the support provided, where you had a kind of estimation of the support provided by government in terms of something which only they could do and which you have an opinion on?
Well, I think testing was a huge issue. And for example, with my young relatives who are on the front line, 3 of them, that doctors could not be tested. So there were a lot of people who were told you've got to self-isolate for 2 weeks. And even when testing started to increase, it was a long time before they were able to get tested. So you had a situation where you'd have a doctor with symptoms, they've got to self-isolate. People they're in contact with have to self-isolate. You couldn't get tested. And I'm not sure how, I think that's probably improved, but I'm not sure how much better that is at the moment. And I think there's still lots of issues about making tests easily available and widely available, not just in hospital, but very much so in the community as well.
Thank you, John. Thank you very much.
Caroline Lucas.
Thanks, thanks, Layla, and thank you so much, John. I guess I wanted to explore a little bit around the idea of how much of these problems that you've described could have been predicted. How much could we have avoided, and how much is genuinely the realm of hindsight? You know, I've lost count of the number of journalists who keep saying, you know, well, with hindsight we now know X, well, actually, we knew quite a lot of this, not least from Project Cygnus in the first place. So I wondered if you could identify, you've obviously said that Cygnus was very clear around PPE. What else could we have known, and should we have been watching and listening to and putting in place at the time, rather than looking back? Okay,
I mean, that's really important question. I think the sort of timeline has been well set out. I mean, I'm sure everyone's familiar with that Sunday Times article, but there was a Reuters report, there's various other reports which have set out kind of what was known and what was done. And essentially from right at the end of December, certainly very early January, there were major concerns in the sort of public health virology community that there was this new virus and it was going to be bad and it was going to come to the UK. And that's the time when there should have been the move to start looking at PPE supplies and also looking at the kind of standard public health interventions that are necessary in a pandemic. So testing and contact tracing. But really very little was done for 2 months. So there was a time lag. I mean, Richard Horton of The Lancet has written about this, and I think he calls it the sort of biggest health policy failure that there's been in this country. So I think as soon as it was known that there was a new virus that was being transmitted from person to person, there were people that were flagging this up right at the beginning of January, but it's more or less, it seems to be more or less 2 months before there's really a significant government reaction to that in terms of preparing. And I don't think there's any way around that. And with lockdown, I mean, it was getting increasingly comfortable that we weren't going for a lockdown, whereas other European countries were. And as you will have heard and be hearing, no doubt, it's estimated that if lockdown had happened just 1 week earlier, there might have been 20,000 fewer deaths.
Thank you. I guess obviously the focus that we want to really keep in mind is how we ensure that we're better prepared for a second spike. And with that in mind, you've described some quite big picture issues around fragmentation, privatization, and so on. And personally, I have a great deal of sympathy with that diagnosis. But given that we're not going to be able to, completely reconfigure NHS procurement and privatization in the next few months, are there concrete things we could do now that would help to address that fragmentation? So I'm thinking of smaller steps than completely reconfiguring privatization in the NHS, but what could we do to make it more streamlined, to make it clearer?
Well, one thing I think is looking at production and production in this country and repurposing industry. And I don't know how far that's been explored, but I remember there were lots of stories in the media about companies offering to produce PPE for the NHS and no one getting back to them. And then on the Panorama programme, there was a company that was producing material for making gowns who was exporting massive amounts to America because their offer to provide it in this country wasn't taken up. Now, I don't know how much that's moved on, but I think what it meant was that we shouldn't be relying on importing stuff from other countries, and we should be developing our own production of PPE. So that's one thing. I mean, I think the real urgent issue is what the government called test and trace, but I think what's better called find, test, track, isolate, and support, because that's a more encompassing term for what needs to be done that ends up with the contact tracing. And so that means, how do you have an effective system? And I think at the moment we've got a very top-down system, centralized system, which does involve huge contracts to the private sector. And yet 40% of people saying the fact that it is being managed by the private sector makes them more reluctant to divulge details. So that in itself is an issue. I think the main thing
by
is
divulging, as in the individuals are scared to divulge details to the companies.
Divulging things like their contacts, who they've been in contact with, which is the information that you want to know. So I mean, a lot has been written, and you will hear a lot more about how contact tracing really needs to be locally based. So it needs to be done by local authorities in conjunction with their departments of health, and bringing on board expertise which hasn't completely disappeared, like environmental health. And then it's people based in the community who know the community, who actually can go out and talk to people, explain to them why they need testing, why they need to isolate, helping them isolate. And there's some really difficult problems, for example, in communities where there's a lot of BAME people who are at higher risk, but in worse social housing conditions where actually isolating is probably just not feasible. What do we do about that? You probably have to open up unused hotels and have facilities where people can be accommodated during isolation. I think for many low-paid workers, those on zero contracts, or those who don't have sick pay, expecting them to self-isolate for 2 weeks and have no income or virtually no income is just completely unrealistic. It's not going to happen. So that's something which financial support for those who have to isolate has to be addressed. And I think part of the community public health approach needs to be building very close links with community organizations that reach out into the community, like faith organizations, for example, and also bringing GP surgeries back more into the center of things, so that they become the focus of testing and managing support for patients who are isolating. And that means more resources going to GP surgeries to enable them to do that. I think all these things are manageable, if there's an acceptance that the current model is not working and actually cannot work. And I think Germany is a good example of how there's central coordination and support, but the money and the personnel has gone into the separate German state public health organizations, and they've had their public health locally built up, and they're doing a much better job.
Thank you so much.
Thank you. If I can, I'm just going to ask a quick supplementary on this area. In the submission, it was made clear that over the last few years, public health at a local level has been diminished in terms of its capacity and expertise. John, is this something that we're going to be able to replace quick enough before a second wave, in your opinion?
I think that's difficult to answer. I mean, I think the answer is we have to try. And there are, for example, furloughed local authority staff who I think could be brought back into work and retrained to work with public health and contact tracing. But you're right. I mean, there's been a huge reduction in funding for public health when it moved from NHS into local authority, something like a 40% reduction, I think. So there are big problems there that need to be addressed. But I mean, the sooner that starts to be tackled, the more likely that we'll be in a better position if things get worse. And I have problems with sort of second wave because there isn't a definition of it. We're still seeing around 2,000 new cases each day in this country, which is far too many. And the second wave has very worrying connotations in terms of the 1918 flu pandemic, when it came in March and it killed millions of people. Then it came back in September and it killed many millions more. And there is some debate now amongst modelers as to whether seasonal variation in coronavirus inevitably means that there's going to be a resurgence in September. Mm-hmm. But at the moment, I would say we're not really on top of the first wave, so it's a bit premature in some ways talking about second wave.
No, thank you, John. Philippa Whitford.
Thanks, Leila. Obviously, just taking forward what you were talking about public health, I mean, it's estimated that local public health teams are actually doing about 8 times the amount of contact tracing as the central call centres. So would you feel that we should be trying to push the government to actually move the funding from that contract? In Scotland, our contact tracing has all been based on being public health led, and obviously we're working on an elimination strategy to keep numbers down. So do you think that would be a reasonable thing for us to be calling for, to actually even now switch from centralized call centers outsourced to directors of public health and local public health teams?
Yes, I think it would be absolutely reasonable, and it's clearly the right thing to do. And Alison Pollock made a statement that if you've got a fire raging in Blackpool, you don't call the fire brigade from London. You know, you want a local team that knows what to do and can move quickly. So I think that's absolutely essential, and that's one of the things which Unite is calling for, that the money goes to local public health and local authority setup.
Obviously, you've already explored with Caroline the issue of how to sort PPE, but obviously the other key player in this is workforce, which you did mention, and you described obviously the fact that you didn't manage to get fully recruited. So do you think that with the potential of, you know, a challenge in the winter combined with flu and COVID, should actually the NHS be continuing with completing the recruitment of returners, so that even if you're not working right now, that people are ready to go if they need to be called on?
Yes, I think so. And perhaps more importantly is retaining the people who have gone back, because certainly a proportion of them have found their way into the contact tracing, but as not the call handlers, but as the second level. But from ones in Unite that I've spoken to, they're having very little to do. You know, they're underused. They're not being able to book sessions. There's nothing for them to do. And I think many of them are experienced GPs who've only retired recently. And ideally, they would go back into their local general practices where they would be functioning around test, track and trace and support. So I think that's probably, we need to look at retaining the people who've gone back, as well as perhaps as bringing more back in, people like me who were willing to go back in but were not required.
It has also been raised that some of the people who've gone back were actually people who had retired early, often because of the pension tax issues and other things. Do you think there's potential there for some of these who maybe were younger than 60, that actually we could retain them properly back into the NHS, in that there are 100,000 vacancies in NHS England?
There's a possibility. I mean, it's complex, isn't it? As you know very well, Philippa. Why do people leave? You know, some people leave because of poor working conditions and stress, and actually it's going to be very difficult to get them to go back. And if you want them to go back, you've got to say, actually, life will be better for you and we'll look after you. And I think if that could be done, there would be people who would go back.
I mean, my local health board, which I've been working with, created a wellbeing centre. They put a consultant psychologist in. How much do you think is being done across the NHS, indeed in all 4 nations, to recognise the mental health issues that will be coming on staff, whether it's post-traumatic or exhaustion, and particularly as we move into catch-up? As an MP, I'm already getting, you know, the emails, why am I waiting so long? You know, it's amazing how quickly the narrative will switch from the job the NHS has achieved to people, whether it's politicians or the public, moaning about, well, why is it taking so long to catch up? And yet it's the same people. So how can we provide that support, whether it's retaining or supporting the people who are actually still in the NHS?
I mean, difficult questions. I think the mental health problems are kind of being acknowledged but I wouldn't be confident about the support for staff, to be honest, because I think, again, that's a resourcing issue, and getting staff to do it. I think that's a huge worry, and it's clear from China and other countries who've been through huge difficulties that kind of post-traumatic stress disorders, insomnia, anxiety become much more common. I think this is something that does need to be tackled, but I'm no longer working in the hospital, but I would not be confident that there's been investment in that area of staff support. I mean, I've heard of things like breakout rooms, but that's literally go in and have a scream and then come out again. I mean, things like that, which possibly have a minor benefit, but I think there are much more things that could be done in terms of staff support. And actually listening to staff and taking their concerns seriously over PPE, for example, would go a long way.
Whereas, as you say, we've actually heard of instances of staff being bullied and threatened, which I think is very disappointing. What would you say are the most urgent things to happen now? What are the, if there was only a couple of things that we could put at the front of our report to help cope with a second wave, and I would have to add, what do you think we should be doing to try to avoid a second wave? Obviously, this is where at the moment the government strategies between the UK government for England and the devolved nations are now very different, in that the devolved nations and the Republic are working on elimination. They're working on zero COVID. So trying to avoid it, but what is the critical things that you want our report to try and get as fast as possible?
Well, in Unite, we think that we should adopt that zero COVID approach, that we should be looking at complete suppression. And it's clear that the Westminster government strategy is quite different. And it's interesting reading the strategy document, because it talks about living with COVID until an effective antiviral treatment or an effective vaccine comes along. But in the next paragraph, it says that both those things may never happen. So what's the alternative? If we continue as we are, I think we'll have flare-up, hotspots, limited lockdowns. I think it'd be very difficult to go to complete lockdown again. So I think we actually need to look at suppressing completely and moving more to that kind of philosophy that's clear in the devolved nations, so that no new cases are acceptable. So that means you have to have a really good, effective test, track and trace mechanism, as we've already discussed. And then I think on the public health front, a lot of people have got the message that somehow it's all over. And you see this from Bournemouth Beach and wherever. The messaging has not been good. And I think there needs to be a very strong, consistent, clear public health message from government that these are the things it hasn't gone away, it's a risk. Actually, it's now affecting more young people, so they're not immune. And we have to continue with social distancing, masking, hand washing, respiratory hygiene, not going to big events. There's a raft of measures that it needs to become second nature, and it should be presented in a similar way as New Zealand, I think. It's kind of it was like Team New Zealand. We're all in it together. We'll fight it together, and we'll work together, and we'll succeed together. I don't think that's really come over, certainly from my perspective. I don't think that sort of approach has been effectively promoted.
Yeah, we've got that summarized in Scotland. It's called FACTS, which is the mnemonic to remember those key messages that you're that you're talking about. But the question is obviously how we get that change. I mean, Independent Sage are calling for that. Otherwise, there's going to be another 20,000 COVID deaths, even without a second wave in England by next spring. Obviously, we talked about that, but is there anything else in preparing? We've talked about PPE. you know, a shift to public health? Any other one thing that you think would be critical to making a difference next winter?
I mean, I think my answer is the one I've just given, that a consistent public health message from government to the population, it hasn't gone away, it's still with us, and there are real dangers in going to the pub or going to open air events where there's lots of people. You know, that it's not gone away, it's still here, and we all have to be extremely vigilant and careful. So I kind of think that you know, there is not one single thing, it's a raft of different things which needs to become ingrained in everyone. And that's really the opposite of the kind of message that we're getting at the moment, which is somehow it's all over and we're returning to some kind of normality. And, you know, time will tell that's a big mistake, undoubtedly.
Thanks very much. Thank you.
Thank you, Philippa. Debbie Abrams. You're on mute.
Bravo. It's a repeat of yesterday. My apologies. Lovely to see you, Dr. Puntis.
Hello,
and thank
Debbie.
you so much for everything that you've been talking about this morning. You've mentioned the importance of the balance, really, between a centrally coordinated approach and local delivery, local resourcing around that. And you also, and I'm glad Philippa picked up on the different approaches that have been taken by the different countries in terms of the easing of lockdown measures. I'm speaking from you from Oldham, and you'll be aware that Oldham has had to implement some new measures because of an increase in COVID cases over the last week. So I wondered, in terms of what your views were around local criteria for easing and then reinstating lockdown measures.
I mean, I think there's some sense in that, but I think it's very difficult to do unless you have the data. I mean, I'm sure you'll be aware of the problems that there've been in dissemination of community test results, again, partly because of the outsourcing of testing to private laboratories and the problems with their contracts and what have you. It seems quite ridiculous. I think if local teams actually have access to very up-to-date, comprehensive data, then they would be able to make sensible decisions. But without that, it's impossible. So it comes down to making testing very available, making sure that GPs and public health get the results as well as the individuals, and that the contact tracers then swing into action. So there's a very clear picture of what's going on locally. And I think there's sort of the way we have it at the moment with the centralized approach is that it's been very slow. I mean, Leicester, for example, where it took ages for the fact that people already knew that there was a problem in Leicester, and then it took about a week before the people in Leicester actually knew there was a problem that they had to react to. So I'm in favour of local management, but it can't happen unless you've got really good information flows and comprehensive data. Absolutely.
Thank you so much, Dr. Puntis.
Well, thank you so much, Dr. Puntis. I really appreciate your time. We're coming towards the end of the session. Is there anything else that you feel that our questioning hasn't drawn out that is a big priority at this time for us to go away and think about? I thank you for what you've said and done so far. I think we've covered a lot of ground, and you've given us a lot of food for thought. But are there any final reflections from you?
I mean, we have covered a lot, and can I just thank you all very much for the opportunity of this meeting. I think number one for me has to be sorting out the test, track and trace. but I think you only do that if your philosophy is to crush COVID, which is the term that's been used in Ireland. If your strategy is you want to stop all new cases or jump on them very, very quickly and control spread, then it follows from that you have to have a very good test, track and trace approach. So you need both a change in philosophy in terms of how we approached the whole pandemic, as well as then developing a really good system for identifying cases and isolating them in contacts.
And how will we know that test, trace, isolate's working well? As parliamentarians trying to hold the government to account, what are the markers that we should be looking for?
Well, one of the SAGE group, the official SAGE group, has said that you need to be identifying 80% of contacts of new cases. And of course, what you then need to know is that those contacts actually self-isolate themselves rather than carry on working and just answer a phone call and tell you they're self-isolating. So I think one independent SAGE has said with a test, track and trace system, you ought to have a series of key performance indicators which are published on a weekly basis, which tell you how you're doing. So we certainly need to know how many contacts have been traced, and then more importantly, or just as importantly, how many of them have actually self-isolated. And of course, as we've already discussed, if they're not supported in self-isolation, then they won't do it. We shouldn't assume that a proportion of people will not self-isolate, either for economic reasons or if they're living in very overcrowded accommodation, it just won't be possible.
Brilliant. Dr. John Purtis, thank you so much for your time. Really appreciate it. You're very welcome to stay and continue to watch the session either from within the Zoom or it's being live streamed elsewhere. But if you feel you've got other things to go and do, don't feel obliged to. Thank you so much for your time. I really, really appreciate it.
Thank you very much, Leila, and everyone else. Thank you.
Well, I'm delighted now to be able to say that we are joined by Neil Dixon, who is the Chief Executive of the NHS Confederation. Mr. Dixon, thank you so much for joining us today. May I call you Neil?
You may indeed.
Thank you. And for those who don't know, the NHS Confederation is a membership body that brings together and speaks on behalf of organisations that plan, commission and provide NHS services in England, Northern Ireland and Wales. And I'll start, Neil, by simply saying thank you very much for your detailed submission, which covered a huge amount of ground. And the purpose of the next 45 minutes or so is to try and drill down into some of the details behind that. So I thank you very much for your time. Can we start with Barbara Keeley, MP?
Thanks very much, Leila, and thanks, Niall. So in terms of the main issues you've encountered during the pandemic, if we can start there, you have raised issues in your submission from the NHS Confederation of workforce capacity, PPE, testing for healthcare staff, performance of test, track and trace. So if I could start by asking you, what are the 3 or 4 issues that you want to highlight to the all-party group in terms of what we could change going forward? So it's the change that we could make that we're interested in now.
I think that's a very valid way of looking at it. I suppose I would have to start on workforce. And again, it may be that in terms of what you can do in inverted commas here is about urging and providing thought leadership rather than necessarily technical interventions. But I think just to reflect on that, we are a people business. We entered the pandemic with more than 100,000 vacancies in England alone, and with a very limited intensive care bed base, and therefore staff to do that. We managed to reorientate the service, and staff have shown incredible flexibility. We managed to entice back, I think it's more than 30,000 doctors who had given up their registration, and we've used lots of staff, including academics and others in different ways. But I think now there's no doubt, and it is a worry, and we hear all the time from our members about the impact on staff of what has happened is very considerable. and I think our members are acutely conscious of this. You may know, you touched on what we do, but we work under two main brands, if I can put it that way. And our NHS Employers brand, where we are NHS Employers, has played a key role with support and guidance to enable organisations to support their staff. And I think it's fair to say that the workforce is not just about the tap, how many you have, it's about also making sure we supply. It's also the plug about retaining those that you employ. And as we look at the effect of the pandemic, I think the effect on staff has been differential. There are those who've been on or on the edge of the front line, and many of them are simply exhausted. They've gone more than the extra mile, and the impact on them and their families will probably, without exception, have been considerable. The intensity of that work and the management of dying patients without their families and having to work in that PPE environment that we've all seen on our television screen, all will take its toll. But away from the sickest COVID patients, I think we've got to think for a moment about the wider, and this is not talked about quite so much, such as, for example, community nurses going into homes without knowing quite what lies within. Think of an ambulance crew dealing with an unconscious patient. They've absolutely no idea whether they've got COVID or they haven't, and then manipulating them downstairs. There will also, frankly, be those who feel a bit guilty and frustrated. I've heard both of those referred to as feelings, because they've not been as busy, or their work has stopped and they've not been able to do what they would normally be able to do. So I think all that means that retention is going to be a real problem for both health and social care. And you know, that there's no doubt that there are significant numbers of staff saying that they are or would like to leave their roles. Now, the historic vacancy levels mean we've already got a problem as we start to resume services and hopefully getting the NHS back on its feet. We're expecting NHS England Improvement to launch a people plan in the next day or so. Frankly, we've never seen a national plan as anything other than, you know, it can be a roadmap, a series of pointers, a main means of conveying strategy and so forth. But it's also got to include money, as it were, funding from government and the kind of levels of ambition, which is a nation that we've got for all this in terms of building up our domestic supply and so forth. But frankly, given the pandemic, the likelihood of multi-year funding not being clear until the autumn, I wouldn't expect this document to be definitive. But we do expect it to be concerned about looking after our people and capturing those positive changes that we have seen, and making sure that we support all our staff. And the issue, obviously, of the virus on BAME staff, which you may want to come back to, is obviously a real concern. But we do expect a multi-year settlement. So if you're asking me, again, what the all-party group can do, I mean, I think pressure on government around that, I think at local level, and a recognition, I think our members recognise this, that it isn't just the tap, it is the plug as well, about how we support staff locally. And make health and social care really attractive places in which to work. Mm-hmm. So that would be workforce. I can stop there or continue on this.
Let me ask you one more question about workforce, because you know the people plan may come along and there's the funding issue, but what can be done in terms? You know, clearly we're all concerned about later in the year, winter, the second wave. What can be done in the short term to deal with the combination that you've just outlined of existing gaps, staff burnout, and possibly anxiety, morale issues due to the pandemic, and the need now to cope with the backlog of elective and other care? Those are all the pressures, aren't they? So we know what happened in terms of the early stages of the pandemic, in terms of returning staff. And use of final year medical students. But what else can be done? Because clearly those issues, a people plan in itself will not deal with those issues in the short term. So what could we be calling for? You know, what measures do you think should come forward first?
Well, first of all, continuation of the relaxation of funding beyond October and through to the end of the year. Secondly, I think in terms of, I would like to see within the people plan a kind of a release of at system level, so at the local level, much greater control over workforce and starting to bring health and care planning together. An awful lot of our members, I think, were frustrated that the government decided at some point to separate off health and workforce, health workforce and social care workforce, whereas at local level, you've got staff moving between the two. And frankly, there's a much greater movement from health to from social care to health, as you would expect, because the levels of pay are so much greater. And sometimes the support for staff is greater as well. So we need to equalize that, and we need to cope with that and look at it as a whole system, not as an individual system. So I think calling for greater scope and for funding to go down to the system level, there are things that people can do at national level. I would commend some of the work that's already been done, to be fair, around the wellbeing support. NHS EI now offers free access to psychological and practical support. There are online support hubs. There's access to a whole series of digital things that can help staff, and there's a mental health wellbeing toolkit and other services that are available, and they need to be promoted in order to help staff to do that. I think at a local level, and I know lots of trusts are actually bringing in psychological support to help them devise and support their staff going forward. So I think there's stuff to be done at local level, which I think our members will take forward. I think there's greater awareness, frankly, than there's probably ever been around this issue, and conscious that it is going to be very difficult. But I wouldn't, as you've said, I wouldn't minimize the difficulty, because I think a lot of staff are tired and exhausted at the moment, and we need to give them as much breathing space as possible between now and a possible either second spike or the arrival of the pressures that will come at winter time.
Well, just on a couple of other things that affect. Can I just ask one more question? Just because we didn't touch on PPE supplies and things like testing of staff or BAME staff and reducing the risk for them. In terms of the things you said about workforce, are there still concerns? Is that part of this picture of concerns among staff? Are there still concerns about PPE, and what more could be done about risk assessments for BAME staff?
So first of all, on PPE, and again, I won't repeat the story. I think the problem has been partly about reality of supply and distribution of PPE, which has been real. I think that's much, much less than it was, but I will not say that in every area, in every place, it is absolutely all right. Perhaps inevitably in such a vast system, you will get glitches, but on the whole, it is much better than it was. And I wouldn't want to say anything different. And that's certainly what we hear from our members. I think it may be there may be more difficulties among some areas of primary care and in areas of social care in other parts of the NHS. I think mostly the issue has been got to a much better place around this. The problem is lack of confidence, frankly, and the fact that originally, and I'm sorry to go back, but the timely and appropriate guidance wasn't there at the beginning, and it is now. Timely and appropriate supplies arriving from the UK and a distribution system that wasn't there, especially for smaller customers or bits of the system, and that meant care homes and community services and primary care. And sometimes government's failure to acknowledge the problems and at times be rather over-optimistic about what may happen. So I think we are in a much better place now. I think they have begun to, they spent a huge amount of money on doing this. In terms of learning lessons for the future, it's clear that our stockpile, we had a big stockpile, was not up to date. It was not flexible enough to deal with a different kind of pandemic from the one that we were preparing. And we certainly didn't have a proper distribution system. So I think all those things I hope have been learned for the process going forward. You mentioned the risk assessment of BME staff. I think it's true to say that we've done, as of now, 80% of BAME staff have been given or offered a risk assessment. So I think that has been, I'm not saying it's a perfect process or anything else, but I think it's been broadly very much welcomed, and it certainly demonstrates how seriously our members, and to be fair, I think NHS England Improvement are taking this issue, and we need to keep on doing. We need to obviously get nearer to 100%. Obviously, the people who won't want to take part and so forth. But I think we need to do everything possible we can to do that form of risk assessment, and of course to continue exploring the reasons why the BAME community has been hit so heavily by COVID. I should just add that we are also pleased that the Confederation has been given the opportunity to host a new race and health observatory, and and we're being funded from NHS England to do that. And we hope that in future that will provide not only a commission and bring together more research on this area, but actually produce actions that the system can respond to in order to try and make sure that we deal with the fundamental health inequalities that affect people from BAME communities.
Yeah, thank you,
Okay,
Neil.
thank you.
And we've got lots of people wanting to come in to question you. Debbie, can I come to you
Very
next?
quickly, now you mentioned about the issues on distribution of PPE. What specific, and I heard this locally as well, so my local acute hospital expecting a delivery, it not turning up, the army being seconded to actually sort the distribution out. What do you understand at a national level the issue was around that?
I think, and I may be oversimplifying this, but my understanding was that whatever was planned at the beginning, the system we had, NHS supply chain or whatever its name was basically an operation from a warehouse with vast supplies of PPE, which thought that it had 240 customers, which meant putting large palletainer's on the backs of lorries and sending it out to that relatively small number of customers. Within 2 days, they found that they actually didn't have 250 customers. They had 35,000 or so customers, including community services, primary care, and of course, elements of social care, which absolutely needed that support and should, in a way, have had absolute access to that support. So I think that's the first issue in terms of the distribution system. It wasn't designed for what it was required to do, and it very quickly fell over, and bringing in the army was the right thing to do in order to try and remedy that. But even that was, you know, pretty difficult. I think they quickly wanted to try and get a system where small units like care homes and so on could go online, make an order, and then they'd respond to that order. They weren't able to do that at first. They simply couldn't cope with it. So that then meant that you were pushing out supplies rather than you were guessing what people would get, and hence your example. I think the other thing to say is that at the other end, it is when you order something, and it could be from China or anywhere else, very largely from China, but it's true, I think, generally of a lot of things that I'm told even the fashion industry has this problem, though the consequences are much less. You order stuff and what you actually get inside the package is not always what you ordered. It's not always the sizes you ordered. It's sometimes not always the quality you ordered, and so forth. So again, once you were beyond working on the stocks that we already had, those stocks were had not been fully checked at the beginning of the process. So I think there were things to learn there. I think there are a whole series of lessons. And again, I'm not seeking to apportion blame, but I think we will now absolutely be sure we've got the right supplies in order for another pandemic. As far as we're possible, we're able to do that. That we're not relying on one country particularly to do all our supplies. And we had no domestic industry at all. Yeah. And I believe the target now is to have a 20%. It'll be a lot more expensive, that 20%, but we need 20% in order to be able to have a decent enough industry. So if we have another pandemic to arise, it's much easier to expand that and then to have to rely less on what will be a wider number of international suppliers.
Yeah, thank you.
Thanks very much.
So I'm now going to move to a comment that was made by Dr. John Puntis earlier about the fact we're talking about a potential second wave when in reality we haven't actually gotten on top of the first one, and that there are still thousands of community transmission cases every day and we're still seeing deaths. There are those who are suggesting that we should be moving to an overall strategy of trying at least to get to zero COVID, so zero community transmission of COVID, similar to the devolved nations who have already said that this is what they want to do. I'm just wondering your opinion of that, Neil. Do you think that's something we should be aiming for?
I'm not a clinical or scientific expert, so I have to be very cautious about this, but obviously we would, the aim should be, of course, to eliminate the virus, and we should do everything possible to try and get to that point. The only caution I would say is we constantly say to government, don't overpromise and underdeliver. So I would not be urging them to make kind of promises about that unless they are confident and the scientists are confident that we can reach them. Mm-hmm. I would say in relation to the second spike issue or something coming, the levels of concern among our members, the people who are leading NHS trusts, who are leading in primary care and all the levels and at the systems, is very high. I mean, of course, there's real concern about winter and the compounding factors there, but also about an earlier spike. We have already mentioned exhausted staff. We're already trying to rebuild other services. So combining another spike while you're trying to dual run and do that in circumstances where it is really challenging. We're talking about possibly at the moment 60% productivity around on the non-COVID side. Mm-hmm. And we're working in which public health services have been cut back, and we've not yet been good enough at reaching into areas of deprivation, which would be one of the key ways in which you would absolutely try and get to zero transmission. Mm-hmm. On the positive side, and I think there are positives, so we've learned lots of lessons in many ways, from how to treat people to how we organize ourselves. We have extra capacity, not only through the Nightingales, but in other settings. So we are much more, I think, confident in relation to respiratory care and so on. We do have some access to additional staff. And I think the other key point, which is not perhaps emphasized enough, is I think relationships locally, and I know they've been variable, so there are areas that have done better than others, but actually they have, almost everywhere they have improved, and there's much more contact and recognition among everybody at local level that no organization is an island in this health and care and local government community, if I can put it that way. Every part is dependent on the other and the contacts they've made. So I spoke to Chief Executive earlier this week, and she said, in the past, we did have conversations with local government and that kind of thing. She said now, during the pandemic, we had daily calls, that they're now reduced significantly, but the relationships that have been built up are really important, and they will stand us hopefully in good stead. So we said at the outset of this business that the NHS and indeed the care system, had the capacity to flex, and we still believe that it has the capacity to flex if we get another spike. But we also need to be clear, as we said then, and we will say again, no system can cope with something that's just too massive and will overwhelm it. And we shouldn't be complacent about that either.
Yeah, thank you very much. Caroline.
Thanks very much, Leila, and thank you, Neil. Two quick questions. The first one, going back to PPE just for a second, and we're very clear in this APPG that we're not seeking to sit here attributing blame, but what we do want to do is to learn the lesson. So I just want to revisit again, just for a second, the point that you made about a company whose job it was to get the PPE to where it needed to be, and they were expecting 250 customers and they ended up with 35,000. Mm. Why did that happen? I mean, is it somebody writing a spec in an office just simply not understanding how the system works? I just want to understand how that could have happened, because sitting here now, and it is a luxury looking back, it now seems pretty obvious that there are going to be so many different demands for that PPE. And I just want to understand why that wasn't clear at the time.
So, I mean, the short answer is I don't know, and you'd have to ask those who are much closer to the process. I think the only small political point I'd make about this is that there is a tendency, and it applies throughout the NHS, I guess, and sometimes throughout government, to have a real concentration on acute care and on the hospital sector and so forth. Now, the hospital sector has done a fantastic job in all this, and they suffered from this, the problems with PPE as well. And of course, the huge concern initially was around the sickest patients and how we would manage to treat and support and care for them. But I think that the result of a combination of perhaps a mindset that thinks NHS hospitals, you still hear it, dare I say, from politicians who always say, I'm building more hospitals and so on, and forget that actually hospitals are just at the apex, if that's the right word, with the sickest patients, of a very complex infrastructure underneath. Now, I think there may have been, and I can't be definitive about this, that mindset that said, well, if there's a pandemic, we need to treat the sickest people. The sickest people will need people who are fully dealt with in PPE, and therefore we'll create a system that did this, and it didn't think through. Now, you may think it's pretty obvious that they should have done. I really don't know, but I think the evidence that we didn't have a proper system of distribution is pretty evident. And the key point is, going forward, how do we create a system which would, and I think we know what it would look like. It would be a system in which every part of the health and care system could go on Amazon-like, if I can use that term, and be able to order what equipment they needed and know that within 24 hours, something would arrive with that stuff on board. I mean, that has to be our ambition.
I mean, I agree with you, and one would hope that those lessons had been learned, but I would just observe that I was talking to our own council here in Brighton and Hove just recently, and they were saying that, you know, there's meant to now be testing in care homes for residents every 28 days, staff every week, and yet of the 44 care homes in our city, only 2 have actually managed to get the testing that they need. They're supposed to apply via some kind of portal to get that. So only 2 out of 44 have actually got it. So it feels like there's something really structurally wrong still, and I guess in future evidence sessions we'll try to tease out what that is.
Yeah, I agree with that, and the testing issue again has been. I mean, I think we're still concerned about the rollout of testing, and again, it is better in the NHS than it was, but there's still testing constraints, and I think the key point of getting access and regularity of testing, which is now absolutely recognised in these care settings, has to be. There's still progress that's got to be made on.
Thanks. Just one very quick last question. In your evidence, you've already very powerfully set out the pressures on staff in the NHS, and in your written evidence, I noticed that you were talking about the considerable disruption caused by pausing non-urgent procedures and the challenge of resuming them. I wondered if there was a learning point from that, whether or not you were suggesting maybe that they shouldn't have been paused, or whether there should have been a way of continuing those urgent cases in a separate kind of structure. I wasn't quite sure what the conclusion was from that observation.
Well, I think that's a very astute observation, I think, and the short answer is I don't think we know whether, and I think this would require much greater study. What we were doing, what the NHS was doing at that time, was responding to a massive unknown emergency which could have overwhelmed it. So you could argue, for example, well, you didn't need any of the Nightingale hospitals, so in retrospect, why on earth did you devote all that money, all that time, all that effort in order to building them? But I have to say that is with the benefit of hindsight, and I still think, you know, on balance, the right thing to do was to assume the worst and to try and plan for that. Now, again, from what we've learned in the way in which all that has happened, if, for example, a second spike came, would we need to, you know, revert back to what we did with the first spike? I very much doubt that. I think we would find ways in which we could keep the 2 services running, albeit, as I said, the non-COVID services will not be able to operate at anything like full productivity, because of the nature of PPE, social distancing, all those other factors which will constrain how those services are provided.
Great, thank you very much. Philippa Whitford.
Thanks very much, Leila. Hi there, Neil. Obviously, the point of this report is trying to trigger thought about preparing for the autumn. So obviously, questioners have covered lots of different issues that you've raised. So what do you think are the most important things, most important steps that need to be taken while we're in this slightly calmer waters? So whether it's a second spike or a second wave, or just the winter combination of flu and COVID, what do we need to ask the government to be doing to get ready for that?
Well, first point is around just making sure that we retain all the staff that we possibly can. Secondly, that there are local plans, which I'm sure there will be, local plans for how every organization, but also how every system is going to cope with various scenarios of both a combination of flu and of a potential return of COVID. So there's the staffing and then there's the organization. Those are the two fundamental things. And I think actually retaining the capacity, the additional capacity that we've got, though possibly using it in different ways. So for example, Nightingale hospitals possibly being used, and Nightingales are different. Some are simply respiratory type, and they might be still used in a COVID capacity, but others might be used in different ways. So it's making sure that every organization is able to plan, and this time actually there's a greater opportunity to plan. But I think recognizing too that there has to be a really comprehensive flu vaccination program, and that means again a flu vaccination program that doesn't just go out and say, well, everybody's got to get a flu vaccine. Again, you've got to target particular communities, you've got to help people, you've got to provide things in different languages, you've got to make sure that you absolutely reach all parts of the community in order to make that the case. I should add, there's one optimistic thing that I don't know might be worth just mentioning for a moment. It's not something to urge government to do, but I think the importance of both effective PPE and effective social distancing by the public, as it were, so the wearing of masks and social distancing and the like, it could be helpful in reducing flu and getting that message across as well. And I gather in Australia, they have seen a reduction in what they might have been expecting in terms of flu deaths already. So I think this importance of washing hands, social distancing and all the rest of it is going to be really important. And again, I think government has a key role to play in getting that message across going forward. So I think those are probably the main areas. And it is, I guess, also, I suppose a message to the centre would be, of course, we understand that you want to monitor every single bit of everything that is going on, and we kind of understand that a bit, but it's also about giving empowerment to local leaders to devise their own strategies and so forth going forward that will make the most of this. Because certainly some of the lessons that we've seen from COVID already, and even chief execs and leaders of healthcare organizations have said this to me, even doctors, dare I say this, speaking to a doctor, even doctors who were kind of a bit resistant to some of the changes in terms of digital and different ways of working have absolutely embraced it. And why have they done that? Well, partly because it's an emergency, but also, frankly, they were given the freedom to do it. So it wasn't about enforcing and regulating and introducing bureaucracy. So there's something about, as we do winter this year, of course, the monitoring should be central, and that's absolutely fine. But it's also, frankly, about freeing up local leaders, working with their clinicians and improving those local relationships, making sure that the local resilience fora who have sort of come to life, and again, they were variable across the country, but I think they've shown what is possible when you get organizations at a local level working together, and you have public health, hopefully much better funded, having a better understanding of what is going on in each postcode within an area.
I mean, obviously, quite a lot of that is to, if you like, local organizations about plans and preparation and empowerment, but trying to get messages to government particularly. I mean, you talk about the public health message to the public. So would you be calling for the government to have a clearer strategy going forward? Obviously in Scotland and the other devolved, we are following the zero COVID. Whether that is the strategy in England or not, I'm not sure the public are very clear what the aim is other than local lockdowns. And I'm sure if we ask the people in Leicester, being locked down locally is just as bad as being locked down nationally, if not worse, because someone else is having a better time than you. So does it not all start with what the strategy is not just to prepare for a second wave, but to avoid a second wave if we can. And as you say, it would impact on flu numbers as well.
Yeah, well, I agree with that. And I mean, you'd have to ask government about the government for England, as it were, in terms of, you know, the detail of what they, our view would certainly be, and our understanding is that the strategy, of course, is to do everything possible to avoid a second spike. Obviously, you can avoid a second spike if you completely eliminate the virus. We are, it seems, some considerable distance away from that. As I say, rather than me call for them to stand up tomorrow and say, we're going for zero, all I would say is, if they do that, please tell us how you're going to do it and be very, very clear about the timescale to do it. Because one of the problems we've had with PPE, with testing and so forth, is over-promising and not being able to deliver. And I understand the enthusiasm, and I also understand that sometimes setting goals can galvanize the system, as the Secretary of State said. But really, we don't want to over-promise what we can achieve. And I think I would take credit to the government for saying, you know, making it clear that the risk of a second spike is real, and not just saying, oh, we're all right now, because it is about everyone, every member of the public being absolutely on guard and being aware of the seriousness and of the presence of the virus. And we've seen in other countries all around the world, again, who appear to have got through all this, then the virus has a nasty habit of
do you not think the messages have been a bit mixed? You know, we heard maybe the end of social distancing in November, hugging each other at Christmas and New Year. And while in the last week, there has been talk about tough times and there could be a second wave, it's this oscillating message that, does that not confuse the public? Whereas we actually need you know, here's the 5 things we want you to do. We want you to keep doing them. And they're not going to change anytime soon, so just get used to it. Whereas there's a lot of change.
Well, yeah, I mean, I'm not here to defend the government's line on this, and I, in some ways, I have a degree of sympathy around the messaging, and I think it applies to across all the devolved countries as well. They've had to change their message as time gone on. Originally they were all saying masks were not important. Now masks are very important, and so on. And of course, as the virus changes, your messaging changes. And of course, the simple message, which at the beginning was all about stay at home, do whatever, and then the government relaxed that, and we're sort of criticized for stopping saying the stay at home message. But of course, you know, you do have to move this thing on, and the trouble is, just as the NHS is finding it much more difficult to start services again, I think, you know, relaxing the lockdown has been even more challenging, because the lockdown message was relatively simple, and most people understood what it was. As soon as you kind of move out to a more complex message, and you are relying on people making their own judgments more than they were in the past, it does become more difficult. But your central thesis is right. Try and keep the message as simple as possible. And I think communication has always been, it was always going to be difficult, but it is difficult in this area. Keep your message as simple as possible, and make sure that people understand what it is expected of them. And I accept, again, when things happen, like, you know, something happening in Spain, you may have to change tack very quickly. And again, that will cause upset and difficulty. But I agree with you. So a simple message, try and keep it as simple as possible and be as consistent as you can, but you will have to change as the virus changes and the demands change.
And without going into them in detail,
what are
the 2 things that you would want us to push hardest for in the report to prepare the NHS? That's your responsibility. So not strategy, but preparing health and social care for the autumn.
Well, I'm afraid our 2 things remain. Funding and workforce are the 2 biggest things that need to be tackled. And there's a whole subsection under each one. And in particular, not to repeat the initial mistake, I think, around all this, which was just to focus on one part of the health and care system and not to be aware of the wider part and the longer term commitment, which is greater funding in England to go into community and to social care over time. and to keep with that commitment to providing that funding, as well as supporting very stretched NHS trusts who, you know, even in the acute sector, have been living with considerable deficits.
Okay, thank you very much.
Nira Wilson.
Thanks, Leila. Neil, in your written evidence, the last point you make is that we need a much stronger focus on the impact of health inequalities on the resilience of communities and individuals to the virus. I mean, obviously, a lot of the health inequalities we've seen exacerbated by the virus are as a result of long-term systemic and structural issues, which will take a long time to address. Is there anything in the short term you think we should be considering as we're making recommendations for preparation for a second wave in terms of protecting those who are most at risk?
Well, I think the first area I'd just raise is public health. I touched on it briefly. The public health service, which was transferred in 2012 in England from the health service to local authorities, has suffered, again, I'm not blaming local authorities because they've been cut very severely, but basically the public health service has been considerably cut back over that period of time. And of course, it is an area which you don't immediately think of, and it's not in front of your face and all the rest of it. So first thing, let's make sure that we rebuild public health services and focus them in particular on deprived communities and lower income families and so forth, so that we get the right kind of levels of support for those families going forward. I think there's also probably more the health service itself can do. So in general, the NHS has regarded itself as a universal service. It provides care for everybody, and that's a huge advance on many healthcare systems around the world, where the ability to pay or whatever is important. But actually, that isn't good enough, and we absolutely recognise. And I think there's a recognition throughout the health service, including right into the hospital sector, that we need to do more to reach out to those who are finding it difficult to access our services or who are not being supported in the way that they need to be supported, and also how they need further help in prevention. So in terms of health inequalities, we know that the biggest health inequality, which is not actually a long-term thing and can be solved in a shorter period of time, is actually smoking levels. So that is a huge cause of the gap in life expectancy, and actually, again, a much bigger and stronger and much better funded focus on how we help people to quit smoking would be one very obvious way, as well as all those other issues, the wider determinants, as you say. Some of them are longer, some are shorter term. There may be better ways. I mean, I believe there's talk now about making sure that there's food into schools, food into families and so forth, and that they get the right levels of nutrition. Obviously, those kind of support. And then the obesity strategy, which we do welcome. I'm sure there's more that they can do. And again, that is a significant health inequality, and again, could be addressed by actions of government. Not least around things like sugar content of food.
Yeah, thank you very much. So that brings us to the end. It's just for me, Neil Dixon, to say thank you ever so much for being with us today. It's been very, very rich in terms of the food for thought that you've added in. Really appreciate it. If there's anything that you feel that you didn't cover that you want to expand on, please continue to give evidence to the inquiry. But for now, really appreciate your time. You're very welcome to stay and listen as we've got Dr. Chand now. But if you've got somewhere else to go, we shan't be offended if you go and do it. You're I'm
afraid I have, but no disrespect to Chand. Thank you very much indeed. I'm very grateful. Thank you
so much, Neil.
Bye-bye.
Well, it's with great pleasure that I see Dr. Chand Nagpal has joined us from the British Medical Association. It's a real joy to have you with us. Thank you so much. And there's a huge number of people I know who want to ask you lots and lots of questions in the short amount of time we've got. So I'm just gonna crack on, and I ask questions to be as brief as they possibly can to allow others to be able to ask questions too. Barbara Keeley.
Thank you, Leila, and thank you, Dr. Chand. In your submission from the BMA, you raised issues you encountered during the pandemic, lack of appropriate PPE, issues with PPE related to faith and gender of staff, issues about workforce and testing, including the lack of availability of testing for healthcare staff. What out of those things in your submission which are areas which we could change going forward, rather than looking back on all the things that were wrong, would you want to talk to the committee about today? So obviously the issues during the pandemic, but going forward, what are the highlights that we could raise for change?
So I certainly think that we need preparedness, and in that preparedness, having sufficient, reliable and transparent information around the provision of protective equipment. I think as we enter the winter months, in actual fact, the demands on the volumes of equipment we'll need, personal protective equipment, is going to be even greater than we had first time round in the first peak, because of course you'll have large numbers of patients with respiratory illnesses during the winter months that will mimic COVID, and they'll have flu. So in fact, to really be prepared and not just have arbitrary figures of billions of units of PPE, but really show what we have information, for example, of how many pieces of kit need to get through. A hospital gets through in 24 hours. There is data, and so to have a proper modelled information of having sufficient stocks, and do it now before we get into the height of winter. So I think that's one learning, because we sort of got into difficulties in the midst of the lockdown midst of the pandemic first time round, but now is the time to plan. I think the second is about testing. Testing is not just regarding healthcare workers, but of the population. And I want to just remind you that the British Medical Association is a trade union, but it is also a professional association. We represent doctors, 160,000 doctors across all disciplines, and our Public Health Committee in particular have been very, and our Medical Academic Committee have been very involved in all stages of the pandemic. And one of the key areas we feel is important is to have a fit-for-purpose test and trace system, especially given the government's change of direction from what was promised to be an app to now not knowing quite when that app will go live. We just need to make sure everything is in hand to deliver proper contact tracing and isolation. So I think that's another priority which is important. I think there's also a public health intervention now that should be taking place, which is doing absolutely everything we can to prevent further spread. I think there are nations that have shown how very proactive approaches to trying to be ambitious and eliminate the virus rather than sort of just control levels. I think that sort of real ambitious approach to rigorous public health measures, whether it's and that is about social distancing, it is about face coverings, it is about clarity about the workplace, and making it consistent and well understood is important, because we want to prevent those issues occurring. I think the other priority is the fact that the NHS itself is entering its busiest part of the year. There is just more illness in the winter months. We have more patients being admitted to hospital, attending GP practices. And what happened first time round is that the way in which the NHS coped was by creating capacity at the expense of our routine NHS services. We didn't have enough doctors or beds and facilities to go around. And what that has resulted in, according to the BMA's own analysis, is 2.5 million patients, additional patients, are now on a backlog for outpatient services, and about 1.5 million fewer operations occurred between the months of April, May and June. So that's a huge backlog of care. Many of those patients are going to have illnesses that are important to treat, or for whom further delay could jeopardize their own health, even their lives. So we have an immediate issue of clearing this backlog in a systematic way, but also making sure we don't create further backlogs by clamping down on the whole of the NHS except for COVID. So I think one of the real important points in preparedness this time is, how do we have an NHS that coexists in providing care for all those seriously ill patients who deserve to be seen regardless of a pandemic, whilst at the same time attending to the pandemic and winter flu as well. So that's another area of priority for us.
I could just ask you one follow-up question then on the importance of testing and tracing. You said in your submission that you believe local public health teams would have been better placed to lead that contact tracing for their areas. So I want to ask you, what is your current take on the issues with testing and contact tracing, and how is the availability for healthcare staff, which has also been a problem? Availability of testing for healthcare staff.
Yeah. So if you remember, one of the real limitations in the early weeks and a couple of months into the pandemic is that healthcare workers were not able to be tested. There wasn't the capacity. It meant many healthcare workers were self-isolating needlessly, wanted to come back to work, but couldn't. And we also, I think there was a more serious issue about lack of testing, is we didn't know level of asymptomatic carriers of infection in hospitals and GP practices. And I think that I don't think we've got firm data, but there's plenty of anecdotal examples that spread was occurring within hospitals, and therefore testing healthcare professionals would have been extremely important at the time. Moving forward, our public health committee feel that their local teams are critical in being able to monitor and take action in local outbreaks and isolating people. That's been a traditional approach for public health medicine in the UK. Now, an app which we were promised can of course augment that, because it automates the ability to identify people. But at the heart of it, you still need public health team. One of the criticisms I've heard from our public health colleagues is that they felt they weren't being given that information readily enough, because a lot of that information was being held at a central level, and also local authorities, as you know, weren't being given that information. So when I talk about public health doctors, I'm talking about the resilience team that includes local authorities. So as you know, the Leicester lockdown occurred, according to the mayor, a week later than perhaps he would have indicated had he had information. So it's having that information locally based, available. And I would go further, because what our public health committee would like is for the public themselves, like what the pollen count is in their area, to know what is the level of infection, and it should advertise to the public. And I think there's a very strong public health message there as well, because if people know that in their area that the infection is rising and it's available to them in a very visible way, it's more likely to result in local communities taking extra precautions and being more careful, and maybe thinking twice about leaving home if they don't need to, etc. So that's what we're looking for. We're looking for local information that's transparent, readily available, and allowing public health teams to have that information to do what they do best, which is controlling spread of infection. That's their livelihoods. That's what they do.
Thank you, Dr. Chan. That's a very practical suggestion there. Munira Wilson.
Thanks, Leila. Dr. Chan, you talked about needing to think about how we can manage a second surge without suspending all non-essential non-COVID treatment. Do you have any particular suggestions on what we can be doing, or what we can be suggesting happens, especially given the fact that there are such serious workforce shortages? Are there any practical suggestions on how we can continue both concurrently?
Sure. So I'll start first by prevention, because I still think that this is the window where we must make sure that as people start to resume normal activities, those normal activities can't be done in a normal way. And we should be very, very clear about the mitigations to prevent spread. So we must do what we can now to prevent firstly, a second spike. I certainly don't want us to take the view that it's an inevitability. We have to be ambitious and talk about suppressing the virus and infection. And that means being much, much more visible in what we're telling not just the public, but workplaces to be doing, and even supporting them to take those measures. So I think that's the first thing. The second is about capacity. We didn't have the capacity before the pandemic. If you go back to last December, you will remember that the NHS was facing record waits of about 4.5 million patients waiting for an operation. That was a record figure. Record waits for cancer treatment, record waits or worse performance figures for A&E waits, etc. So we didn't start with infrastructure. What we have done now is, of course, during the pandemic, to some degree, learned to make use of the workforce productively. And there is, I think, something to be said about that, the use of technology, and therefore allowing the workforce to stretch further in terms of productive ways of working. We can certainly come back to that. We've got, of course, some retired doctors and medical students who've stepped up, and what we should make sure is that they don't just all get be told that their services aren't needed. We need to make sure that that we have availability of those that are willing and able. And with the retired doctors, I just want to be clear that what we're not calling for is for doctors at an older age to be put at risk. There is plenty of work they can do that doesn't put them at risk, but provides services for the NHS. There's also scope for patients themselves to be able to self-manage much more. We saw a bit of that during the peak in terms of self-monitoring of oxygen levels with pulse oximeters. So you actually reduce the demand of necessarily attending in a healthcare setting. What I also think is we need to make sure that the current backlog is dealt with, because the patients who've not been seen are patients who may have urgent problems, cardiac patients, respiratory patients, neurological patients. So we need to now systematically, and what I've asked NHS England, Simon Stevens, Chief Executive, to do, and the BMA is very happy to be part of that discussion, is we need to systematically make sure that those patients who are most in need now and who haven't received treatment are treated now, because what you don't want, well, first of all, it'd be wrong for their health to deteriorate, but what you don't want is additional workload because we didn't address the health needs of people who need to be treated now. So I think we need a systematic approach. We also learned from the experience of the Nightingale that many hospitals felt that they were able, with the right support, to manage peaks of demand. So we perhaps need to be making sure that we're not only thinking about new external sites. I had a lot of colleagues, members in the BMA, who came to us and said, well, you know what, Nightingales are being built, five new hospitals, but we would have liked some resource to bolster our ability to care for patients. So I think we need to just make sure that we're planning in the right way so that there isn't wasted capacity or duplication of capacity. Remember also that if a doctor is in a remote hospital like a Nightingale hospital, they're not in their main hospital. And moving forward, we should be making sure that doctors are able to carry out some of their ordinary NHS work alongside the COVID-related work.
Thank you, Dr. Shan. Debbie Abrams.
Thank you, Dr. Nagpal. It's lovely to see you again. I just want to pick up on something that you mentioned earlier on in your evidence, which in fact, it was particularly about the contact tracing and what was said originally about having a workable app. And there were a couple of other points that you mentioned. I sense that there's an issue in terms of your confidence and possibly other health professionals' confidence in terms of what is being reported, either by the government or more broadly in the various press statements and conferences and so on. Has that affected the level of trust of either the public or health professionals? And if so, what can be done to restore that trust so that we know that as we go forward, messages will be adhered to?
I really think that what the public and the profession want is just honesty about the situation and transparency. And, you know, if there are challenges, just tell us there are challenges. So if I look back at the lessons we can learn, you will know that and I've got sort of, you know, information to back this up, because it was clear that we were told that there was a sufficient stockpile. And we were told that it was not that the NHS didn't have the supplies, it was just there to be sent to us when we needed the PPE stockpile, that is. And then it transpired that it wasn't reaching us, and we were told it was down to transport limitations. And then we later on found out that there probably was not the supplies in the first place to really address the demand that we needed in the pandemic. And I think that it would have been helpful just to be clear at the beginning that there were issues around the level of stockpile, so that we could all be aware, rather than what was happening was an expectation and then finding the reality not meeting the political pronouncements. And there were pronouncements saying, rest assured, we do have sufficient supplies. That was in March, the beginning of March. On the testing, similarly, and sorry if I can go back to the PPE, and then I think talking about how many units of PPE are delivered, in a way, those are just blinding us with figures. It doesn't really matter whether it's 1 billion or 2 billion. It's whether it's available in a ward, whether it's available in a GP practice that counts. And then finding that those figures were based upon a pair of gloves being counted as 2 pieces of PPE. I think all of that doesn't really make sense. We just need some clarity, and I think the same would apply moving forwards, because we've been told again of how many billions of units of PPE are going to be available in the coming months. That we've been given that information, but that doesn't mean very much. What we should know is what is the likely utilization of PPE that we can model and project that over the next 6 months, including allowing for a flu outbreak, and say, have we got enough to cope with that? And if we haven't, let's address that now. So I think that is one, the transparency is important. And the same for testing, because it appears, we heard later on, and we heard this from the government itself, that there was an issue about the capacity. But at the time, we weren't advised that the reason why we weren't doing contact tracing, because I think it was on the 12th of March or so, in the beginning of the second week of March, the whole approach to identifying someone with COVID, isolating, contact tracing, was changed to a policy of self-isolation and not searching for positive cases or contact tracing. And if we were told that, look, it's because testing isn't available, we don't have the capacity, then I think that there could have been a greater concerted effort to deal with the problem, rather than sort of just say that we were carrying on with trying to contain the virus, because it was clear that there were issues, and I think it's important to be open. So if we can be open, what I would suggest is that moving forward, there should be, as I said, a modeled extrapolation of the demands of PPE, so we know that the numbers are there. And the second would be a modeled approach to the volume of testing required, but secondly, the operational element that would back the testing. So what we were told initially was 10,000, then 25,000, then 100,000. But what was happening on the ground was that the test may have been available, but they were taking, in some cases, up to 2 weeks to get a result. And from our own healthcare workers, doctors were telling us they were waiting 3 or 4 days on average. So it isn't just about these statistics. It's about being clear and open with the public and the profession. I think that's a really important, and people will understand pressures if you're open. So that would be my recommendation for the future.
Great. Very quickly, Dr. Chan, we noticed in your submission that you mentioned specific issues around PPE and those who have a faith, and the issues around getting PPE that's correct. Can you tell us a bit more about that and what we can make sure to do about it so it's addressed?
Sure. So there are 2 things about, I'll speak also about the BAME doctors who have been affected in the community, but on the issue of protection faith, the good thing is that there are face and head coverings and ways in which to protect that allow for accommodate for faith, so accommodate for having a beard, accommodate for women who don't want to have a bare below the elbow policy, which is what the PHE guidance has. So there are ways. What we found was that those alternatives were not readily available in hospital trusts in particular, and therefore some doctors were being put under pressure to either wear PPE that wouldn't have given them the same protection, or feel that they were being difficult, or even worse, have to accommodate their own faith-based requirements to wear normal PPE. So what's really important is we know that, and now moving forward, we should make sure that those adapted forms of PPE are readily available. So that's important. And I think there's no reason why moving forward we can't assure that that happens. The second point I'd make was not about faith, about the BAME community at large and for doctors, because remember that the first 10 doctors who tragically died all came from a BAME background, the vast majority from overseas. And on the 9th of April, I called for a government inquiry to look at this, not for the sake of having an inquiry, but the most important thing was, first of all, this was alarming, because even if you allow for variation, that there are greater proportions of BAME doctors than the general population, or healthcare workers than the general population, it just didn't make sense that you're 100% of all doctors had died from COVID being from a ethnic minority background. And what we wanted was to ensure that we put in place mitigations from that point forward. Unfortunately, since I called for that inquiry, which then did occur, we've seen, I think, around 40 doctors have died, 95% of whom have all come from a BAME background, which is, a statistic that we've never come across before. And 61% of all healthcare workers who've died have come from a BAME background. And we've also known that the public at large, in terms of communities, have suffered badly. So, so on the issue around culturally sensitive issues of this pandemic, we need to really learn lessons and make sure moving forward those are taken on board. So that is about making sure that the public health messaging is very clearly culturally tailored, not just in language, but in being culturally tailored in a way that's understood by ethnic minorities. We do need to address some of the health inequalities that have shown themselves to be a cause of the disparate way in which the virus has impacted on communities. We also need to understand and act on the messages we got as a BMA regarding the healthcare profession, in particular doctors, where when we carried out surveys asking doctors to tell us whether they felt adequately protected by PPE or whether they felt they were under pressure to see patients without sufficient PPE. 3 times as many BAME doctors told us they were under pressure to look after patients without protection than their white counterparts. So there's a cultural aspect within the NHS and the health service itself, which needs to be making sure that our BAME colleagues are not under undue pressure. They should be able to speak out, and they certainly should be protected because we now know that if they get the infection, they're at higher risk. And this is on the back of a previous BMA survey that showed that doctors from a BAME background are twice as likely not to feel confident to even raise a concern about patient safety, because they worry that if they bring up an issue of safety, that they will somehow be blamed or face some reprisals. And we've got to eradicate that culture because I think that has played a part in our BAME doctors feeling under this pressure to carry on working when they felt they've not been adequately protected. And that does relate also to the faith-based issue. So we've had doctors for whom fit testing of masks hasn't worked. Now, fit testing is for doctors working in the most contagious areas. The mask has to have a very tight seal. Plenty of members have contacted us saying they failed the fit test, but hospital managers have said, you need to carry on working. Now, you need to be able to speak out if that's the case. So I think there's a real message to be learned moving forward, that no one should feel in any way afraid of speaking out, and the system needs to support anyone who feels that they're at risk and or has any other concerns they want to share. So I think there's a lot there that around the BAM issue that we need to learn.
As a related matter,
yes.
So just on a related matter, we've noticed that there's been relatively low take up on the life assurance scheme so far. Do you think there's more that we need to be doing the government needs to be doing to advertise this, or is it well understood and well known and people are applying, it's just taking time?
So I just want to be clear, when you say the life assurance scheme, that we're speaking about the same life insurance that you're mentioning.
So this is the new scheme that the government introduced for frontline workers, whether they get 60,000, their families get 60,000 should they pass away. And the recent data shows that only 19 have had
Yes.
that accepted, which is very low compared to the numbers who have actually passed away. So I was wondering if there was more that needs to be done on that.
Absolutely, we must. I think it's really important that this is disseminated much more visibly to healthcare workers. It's really important for their dependents to know that they can be looked after and be given some support. So yes, I agree with you. I think the other thing that I didn't mention, which is really important for the BAME healthcare profession, is risk assessments. Because when we found that these trends had emerged, the first thing we asked for at the BMA was to do the review, but in addition, put in place mitigations. And too many weeks passed by without that happening and without any central directive to risk assess, and then secondly, what that risk assessment should look like. We're now in a position where in July, still about a third of doctors had said they weren't aware of their providers doing a risk assessment. I'm pleased that NHS England then put a directive making it compulsory within a 4-week period, which I think is ending now, for all doctors who are at risk to be assessed and mitigations put in place. But that I think moving forward has to also form part of our preparedness. And just to say that a doctor who is at high risk, and this certainly the BAME status is a risk in its own independent right, which we didn't know at the beginning of the pandemic. And when you score that against other risks, if a doctor is in a high risk, meaning that should they contract coronavirus, it's a serious risk to their health or lives, it doesn't mean that they can't provide a useful service. There is ample opportunity to work in low risk areas, in a non-infectious areas, ample opportunity to provide services remotely or virtually or by video consultations, even support NHS 111 for medical advice. There's ample work available. So we need to prepare now to make sure that those doctors who are at highest risk are protected, whilst mobilizing those others as well to be able to focus, if they're at lower risk on COVID.
Thank you. Caroline Lucas.
Thanks very much, Leila, and thank you so much, Dr. Chand. What you were just saying, actually, if I could just pick up this issue of the risk assessments and how that ought to be rolled out more widely. I had heard, but maybe this is wrong, but I had heard that one of the reasons that some doctors were potentially reluctant to go through a risk assessment is that they may be then transferred to a job where the terms and conditions and salaries were less good. Is that something that you've come across? And if so, is that something that we should be presumably looking at very, very quickly?
So I'll be honest, I wouldn't say that has been an issue that has been brought to my attention as any significant issue. What has been the biggest complaints that I've been receiving from members is that they haven't been given a risk assessment, and as a result they haven't been able to be assessed in terms of what would be safe for them. I hope that as we speak now that those risk assessments have been concluded, but there is a second stage. It isn't just about a tick box exercise and saying you've risk assessed. It's what you do next, and that leads into exactly your point, that what you do next needs to be providing that healthcare worker with an alternative that is safe for them, safe for patients, but certainly not one that reduces the terms and conditions of their work or their pay. And I said earlier about the backlog of care. There is a huge amount of non-COVID work that the NHS has to attend to. So there's plenty of work to go around. So there should be no reason. It would be unacceptable for anyone to fear having an assessment thinking that they would have worse pay terms and conditions. That would be unacceptable. And if there are any examples, I'd be very happy to take that and challenge that.
Thank you. I'll follow that up separately. I appreciate that. I guess I was going to say as well, just in terms of the evidence that you just gave around the figures on the confidence of BME staff to challenge the idea that they need to work without enough protection. I just wonder if you believe that within the NHS there is a systematic process going on that will tackle what does sound like racism. I don't use that word lightly, but it does sound like that's what you're describing.
Yeah, I mean, this has been a problem for the NHS for a while, just not just the BMA, but other done surveys, and it's shown, twice as high levels of bullying and harassment on BAME doctors compared to white counterparts. We know that disciplinary referrals are far higher against BAME individuals by their own employer. And when the General Medical Council looked at this, they felt the bias was occurring at an employer level, not at their level, because they were just receiving greater numbers. And that's because I go back to the sort of the mindset of what goes through a BAME healthcare worker who feels afraid that they'll be bullied and harassed. They are reporting that at a higher rate. They therefore feel less likely to fend for themselves, speak out. They report higher levels of not feeling included. And we know that when you're included, you feel stronger, you've got greater advocacy. We know that there's differential attainment in terms of the BAME healthcare workers, in terms of doctors. The higher you progress, the smaller the proportion of BAME doctors. BAME doctors are less likely to be shortlisted consultant positions. They're less likely to be offered consultant positions. More BAME doctors work in a grade below that called a staff and associate specialist grade, very much patient front facing, not having leadership roles, managerial roles. So during the pandemic, many have felt they've been the foot soldiers because they haven't been doing the other work, that they've been just seeing patients. This is a very serious issue, and it's not bringing the best out of the workforce. I think there's a more important message here. It's just not that it's not fair. It's not fair. It's causing pain and anguish for a lot of healthcare workers who are disadvantaged. But it's actually preventing the NHS get the best out of its workforce, because many BAME doctors are the brightest of the bright. They are exceptionally talented and capable, and we are dumbing them down if we are not able to provide them with that sense of real opportunity and achievement and celebrating their talent.
So can I ask you then very quickly, I'm sorry, I'm mindful of time. I can see Layla looking a bit worried. But can I just ask you then, what can be done now? Are you confident that there are enough processes in place that can begin to address that? I mean, both because it's completely wrong in its own right, but also because, as you've just described, it has an impact on the risk that we are putting doctors at, and indeed other health staff.
Yeah, I think there needs to be really clear central messages about having a workplace with a culture that allows openness, learning, not blame, encouraging people to speak out so that the system improves. This is a major paradigm shift, but if there's ever a time, this is the time to do it, because we've seen the impact of I mean, when you look at the statistics around the deaths amongst BAME healthcare workers, and it's not just doctors. We've all seen footage around the Filipino nurses, etc. We must change the culture of the NHS now. I think it can be done, or it can begin to be done if there is a real clear message from the centre, and you then follow that up with some real action points in leadership in organizations. Then that leadership needs to be very clear about what inclusivity means, what is not going to be tolerated, and making sure that everyone understands the rule book and the benefits of creating inclusivity. We will have actually a better NHS, and all the evidence shows that inclusive workplaces are happier for everyone. So I just think this needs clear leadership right from the top, and disseminated through to the operational front floor. And on that note, we called for this review. As you know, the review was finally published, albeit a bit late. There was some delays in the publication of the Public Health England review, and we're now told that Kemi Badenoch is the health minister who will be taking this forward. But we haven't, ourselves at the BMA been involved in further in that bit. So time is not on our side. We need to just make sure that these commitments are followed up by real action. And I think that those the solutions, you're right, will not happen overnight. But there are some things that really can be done to change culture quite quickly if there is a proper motivation from those that are from the top right through to those who lead NHS organisations, making that cultural change.
Thank you. Philippa.
Thanks very much, Layla. Hi there, Chand. We're trying to very much focus on the things we want government to do now within literally the next few months. Now, you've talked about BAME and obviously the sad loss of staff. But if you look, what is quite striking is the deaths have not been among those in intensive care and A&E. Often been people in what would have been considered the less exposed. And I wonder how much you feel that is in relation to Public Health England's PPE guidance that did not include gowns, which is part of WHO, and therefore you have people who are working either in COVID areas or possible COVID areas just in an apron, a mask and a set of gloves. Because we've seen also in the serology tests, it's often cleaners, porters, nurses, not the intensive care people who appear to already have been infected.
You raise a really important point, and I think that what has occurred in those high-risk settings has been both the adequate provision of PPE, so there's not been an issue of people not having availability in the same way as lesser risk areas, but secondly, protocols and procedures on how to don and doff the PPE. So in those other areas, I think one of the issues that were overlooked was in March, PHE guidance was not in keeping with the World Health Organization guidance. It had not advocated, for example, the use of eye coverings in all areas, and certainly not in GP practices, and also it didn't advocate the use of masks in non-COVID areas. Now the point is, there was no such thing as COVID and non-COVID, because the infection was spreading, including within hospitals. We have examples from some doctors who were in non-COVID wards in March, who were told you cannot wear a surgical mask. We don't have enough supplies. You're not a COVID ward, so you can't wear them. And yet those non-COVID areas became filled with COVID patients, because patients themselves developed the infection whilst in hospital, and many were asymptomatic. So you're absolutely right that there has not been the same rigor around the use of PPE in all settings in hospital, whilst there was clearly a focus in intensive care in some A&E settings. So it needs to be now across the piece.
Is that not still a problem, in that, okay, in the 2nd of April, PHE updated it and eye coverings are at least optional. But if you are working in a COVID ward, it is still just a surgical mask, eye coverings, apron and gloves. And this guidance was given to all 4 nations.
Yes,
so
yes.
Is there any pressure going to actually change those guidelines?
Sure. So, okay, so what the discrepancy at the moment between the PHE guidance and the World Health Organization guidance relates to, one, the use of wearing of aprons rather than full sleeve disposable gowns. And I'll tell you what the issue there is, that if you're wearing an apron, the clothing underneath, which is exposed, will be potentially infected. And as a GP, I can tell you what, that's a real issue for us, because then what you do afterwards. Whereas if you wear that clothing will be infectious. We're not in a situation where we can just keep changing our clothes or change scrubs, etc. So with the full sleeve disposable gown, you're protecting everything underneath. Now, we've taken this up with Public Health England quite directly. Members have told us that they're not happy with this guidance. Public Health England's response, and I'll quote what they say, they believe that their bare below the elbow policy, which is the wearing of an apron with scrubs underneath, provides their version of the equivalent protection. That's Public Health England's advice. As I've said, I don't see it having practical help for those who carry on wearing their clothes, because their sleeves may be infected, So this is an issue. What I've also been told is that the NHS hadn't stockpiled full sleeve disposable gowns either, because of this bare below the elbow policy.
I think my understanding stockpile had no gowns in it, and it does sound as if the guidance was made on the basis of the stockpile rather than WHO guidance. Just a final question following on from that.
We're on borrowed time, Philippa, so
I know that.
Very, very short.
How can we create COVID-free either areas or hospitals, because that will be critical to next winter maintaining cancer services, surgery, etc. So what's the BMA's view on how we do that?
I mean, there's two answers I'll give. One is that we need to make sure that testing capacity is such that we, well, first of all, before a person is admitted to hospital, we've got the government have announced how they want to address that for elective care, at least. So you make sure that you minimize as far as possible, or you identify those that are COVID-free and put them in such areas, but you continue with regular testing. And I would say the second point is, I think we mustn't, even if it is a non-COVID area, we mustn't think that reduces the need for continuing to wear masks and gloves and take all of those precautions, because we know that no test is foolproof. And what you do not want in a healthcare setting, in a ward, in a hospital with other ill patients, is to have people who may have slipped through the net and then infect others. So my answer would be that you need testing done in a systematic way and ongoing to assure ourselves that those areas are, as far as we can know, COVID-free. But secondly, continue to behave as if all patients are potentially infectious, even if it's a COVID-free ward, and you carry on wearing face coverings for patients as well as for healthcare professionals. I think there is no scope for complacency here.
Thank you, Dr. Shen. Munira Wilson, final question.
Thanks, Leila. Earlier on, in response to an earlier question I asked, you talked about the importance of prevention and mitigating the spread of the virus, and you talked about suppressing the virus. I just wanted to unpack that further. Do you think we could realistically have an objective or a strategy to get to zero COVID, essentially? Do you think we can suppress it that far, or do you think it's just a question of mitigation? And to what extent should this be a central plank of the government's strategy, as opposed to just not overwhelming the NHS?
I think that, and I think Independent Sage have also suggested this, we should have a mindset and aim for that, because if you aim for that, you will then, your actions will follow, because what we have at the moment is not very, in my view, we're not doing everything we should in trying to contain the virus. So if I look even something as simple as our messages of social distancing, we're told that social distancing is still 2 meters or 1 meter plus. But I'd ask any of you, do you think any member of the public understands what 1 meter plus means? What does plus mean? And as a result, we're resulting in the public thinking that social distancing, many don't really understand this because it's not clear, and therefore they're not socially distancing. If I look at the example of face coverings, it was actually in May, I think the 21st of May, that the Prime Minister announced that face coverings should be worn by the public. Now, if you want to suppress a virus, you wouldn't just make an announcement and then just leave people the free will, whether you then follow that up with a very systematic approach to make sure that happens. So what I mean by suppressing is you take an attitude that says, we want to do absolutely everything to make sure that the infection doesn't spread. So that needs a much more robust approach. And so if I look even at the public health transport of face coverings, why public transport? Why single out public transport? Why didn't we have shops at that time? The evidence was changing. If the evidence was good enough for a train carriage, the evidence is good enough for a supermarket queue. So it's and even now, the staff in supermarkets don't have to wear face coverings. And as for social distancing, it's not being implemented in many workplaces because it's not logistically possible to. But has that been disseminated? Has that been done with the vigor, the determination to say this is a virus that spreads in one way only, which is that if people who are infected or anyone who's infected is close to another, you transmit the virus. If you're not close to each other, you won't transmit it. If everyone was to stay at home, we couldn't have a society where everyone stayed at home. The virus would stop spreading. But the point is, I'm not sure that sense of clear, single-minded determination to try and do everything we can is being done. And that's what I mean by suppressing, to really take the attitude that, yes, we can resume normal living. You can go out, you can do things, but make sure that we have very clear messages about what is expected of both the public and workers to stop spread. And there are measures that can be taken. And I think at the moment, I see too many examples of the potential spread, just walking out into the high street, looking, peering through shop windows. Too many examples. If a hairdresser, for example, wears a visor without a mask, that's not going to suppress the virus. Has that message gone to all employers as to what needs to be done to stop spread of the virus? That's what I mean by suppressing. Have ambition, have that mindset. And if you look at the figures at the moment, the last ONS figures from last Friday, the weekly figures, the infection rate has increased. We're now seeing about 2,700 new cases a day according to the ANS, compared to 2,500 the week before. And so I think now is the time we must be much more robust and rigorous around how we mitigate spread.
Fantastic. Well, Dr. Chan Nagpal, thank you so much for your time. I recognize we've taken 10 minutes over the time you'd given us, and you're very generous with it. That brings us to the end of this oral evidence session. Thank you so much. The first of ones we will be doing weekly. The live stream will soon be ending, but there will be another where we'll be talking to bereaved families and those who are suffering from long COVID next Wednesday, the 5th of August. So I hope those who are watching will join us then. And thank you again, everybody, for your participation today. Thank you very much.